Guys, this is Mobeen. We are talking about the tumors of the lungs, and the lecture today is about pathogenesis and the histopathology with the paraneoplastic syndromes associated with the tumors of the lung. Now, lung cancer has become the leading cause of deaths by the cancer in the United States. It used to be more prevalent, the incidence used to be more in men. However, that is on the decline, and unfortunately, the incidence and prevalence in women is increasing. Now, an important thing from STEP's point of view and from clinical point of view is that how are the lung cancers primary only, or there are secondary as well? So remember that primary lung cancers are about 5%, but there are a lots of secondary lung cancers, which is the other cancers metastasizing to the lungs. And similarly, as a student and as a doctor, as a practitioner, healthcare practitioner, you should know where the lung cancer will metastasize to. So I have two very cute pictures of the monsters for the lung cancers that I would show you today. That would help you remember the secondaries coming to the lungs and secondaries going from the lungs. Generally, as you can see here, bladder, breast, colon, and prostate are the ones that secondaries come from to the lungs, and from the lungs the secondaries go to brain, adrenals, bone, and liver. Now, patient's presentation is mostly like a presentation of somebody who has a problem with the respiratory system, especially a problem that looks like an obstruction. So what would that be? The patient would come with dyspnea, the patient would come with wheezing, hemoptysis because of the bleeding. There may be abscess and cavity formations, both because of the cancer itself and because of the obstruction of the airway, which would cause the distal part of the airway to collapse and form an abscess and cavity. There may be air fluid levels because those cavities would partially drain, and they would rupture into pleura or into the airways, and they drain, and the air fluid levels will be seen. Of course, then the other signs of bronchial obstruction will also be observed. Complications are important. So from a complications point of view, it depends what is the site of the cancer, and what is the size of the cancer, and what structures it is impinging upon. Secondly, there are paraneoplastic syndromes where the cancer cells produce hormones that then create excess of that particular hormone and create the symptoms like the excess of that hormone. So what are you going to see? Remember, with the superior vena cava syndrome. So what happens is, if the cancer is central and on the right side and it presses on the superior vena cava, then what would happen? The return of the blood to the superior vena cava is obstructed. So patient, when he wakes up in the morning, he has swollen face. Secondly, you would see that the patient has superficial veins that would now drain the blood from the upper extremities and bring it to the lower side and then bring it back to the heart. So I'll show you a picture of superior vena cava syndrome. Pancoast tumors are the tumors that appear at the axes. Most of the time, small cell carcinomas can appear as Pancoast tumors. These tumors, depending upon what is the size and where they are located, they can compress on the structures there, for example, brachiocephalic vein, or for example, brachial plexus, or for example, laryngeal nerves. So depending upon what structures they are pressing, there would be syndrome associated with that. For example, let's say if the veins are pressed, then there may be swelling of the arm, upper face, and so on. If there is destruction, which is very common, destruction of the superior cervical ganglion, then Horner syndrome would appear. And if there is a laryngeal nerve that is being pressed, normally the left one, because it comes down all the way, then the hoarseness of voice will be there. And it is even possible that dyspnea would be there if the cricothyroid muscle becomes paralyzed. So effusion, pericardial effusion, pleural effusion are common as well. So let's continue our discussion. So here is the two monsters. These are very cute little monsters, and I think these are interesting for you to see. Look, on the left, this is the monster. This monster is the one that is sending secondaries to the lung. If you look at both of these monsters, you see they both have one leg. One has a little bit of a flexible leg and the other one is a rigid leg. They both have two eyes and they both have a head and they both have one thing wrapping around that leg. So let's start on the left side. This is the areas, the tissues from where the lung cancers will metastasize to the cancer of that tissue will metastasize to the lung. So if you come from top down, bladder is the first tissue. Then down here for the eyes are the breasts. So the breast is very common site from where the metastasis occurs. Below that, the leg is made up of colon, and then colon has a prostate wrapped around it. So that is weird. Ideally, it should be urethra attached to the bladder, but there is colon here. So that is these are the tissues from where metastasis can occur to the lungs. Now on the right side, if you see here, this one is a cute monster that has brain for its head, which is better than having a bladder for its head, and the leg and the body is made up of a bone, and that is why it is common with the patients who have the lung metastasis to the bone. They might have bone aches and the fractures. And for the eyes, this monster has adrenal glands, which tells you that the lung metastasis or secondaries can go to adrenal and finally liver as well. So these are the two monsters that would help you remember the metastasis to and from. Okay, epidemiology. As I said, incidence is reducing in men, increasing in women. Normal age range 55 to 65 is where these cancers normally appear. Most common problem is the smoking. And what happens is, why does smoking cause the problem? Every time the patient is smoking, there is irritation of the lung epithelium. That irritation can result in continuous abuse and finally cause genetic mutations in the cell. Those mutations then are cumulative. So once the cell becomes mutated, it's replicated. Cells are also mutated. You put in more smoke on top of them, they get further irritated, they get more mutated, and so on. And so accumulation of mutations occur, ultimately leading to the cancer. In the progress, I think you've done that in the cancers. First hyperplasia occurs, then dysplasia occurs, then metaplasia occur, and then the carcinoma in situ would occur. Radon gas, asbestos, some metals, pollution, tuberculosis, but keep in mind smoking. Classification. So from a therapeutic point of view, that is, as a clinician, when you are going to be treating the tumors, you should look at tumors in two groups. One that are going to be treated by chemotherapy, and the other that can be treated by chemotherapy plus surgery or surgery alone. So what are the ones that are treated by chemotherapy? Look, small cell carcinoma associated with the cigarette smoking, mostly central, very aggressive, is usually treated by chemotherapy. Now the question is why? And it's very interesting. Most of the time when you diagnose someone with the small cell carcinoma, by that time they already have gotten the cancer metastasizing to other tissues. It is already spread. The stage is already advanced. So at that stage, it is usually counterproductive to do a surgical resection because it is so much spread out. It's not possible to do surgical resection. So in such cases, chemotherapy is given. Well, if there are Pancoast-like tumors, then radiation might be given as well. And why radiation? Because a tumor might be present near the structures where you have a danger or a risk that if you are doing the surgery that you might damage other important structures. So in such cases, chemotherapy plus radiation would be done. Then there are those tumors that can actually benefit from surgical resection. So these are the two therapeutic classifications. So those cancers that can be removed surgically are called non-small cell carcinomas, and those that can be taking advantage of the chemotherapy only are the small cell carcinomas. Now, within the non-small cell carcinoma, we have adenocarcinoma, we have the large cell carcinoma, and we have the squamous cell carcinoma. So this is therapeutic classification. Pathogenesis is very, very simple. It's basically the same as with the other tumors. The only thing is that in the lungs, the aggravating or oncogenic trigger is usually pollution and smoking. Because we have epithelium there, epithelium is replicating all the time. So that is a positive and a negative both. Positive is that epithelium is replicating and renewing and refreshing so we can get new cells. The danger is that if we have created mutations in those cells, then these would start accumulating in the newer cells and more such cells would be produced, and that would accumulate the problem leading up to the cancer. So if you see, most important early signs are inactivation of tumor suppressor genes present on the 3B. And this is very interesting that even the patients who have benign cancers, their epithelium shows mutations of the genes. Similarly, even the smokers who yet do not have cancers, their epithelium starts showing and exhibiting the gene mutations. So then the question became why that gene mutation is not causing a cancer. So that the study is that these mutations slowly accumulate, finally reaching a point where it becomes cancer, and that is how the process is. In the late cases, P53 and KRAS mutations are common. Now, usually the cells undergo hyperplasia, dysplasia, metaplasia, as I said before. So just be very, very much aware of that in your test as well. If they give you sequence of, hey, what would happen, hyperplasia, dysplasia, metaplasia, especially for the epithelial cancers, those cancers that are going to take origin from the epithelial cells or neuroendocrine cells, the cells that are making serotonin, also called Kulczycki's cells. These cells give rise to small cell carcinoma, and that is mostly associated with cancer. Now, here is a quick table. I would let you read this, but important thing is this, that there are two basic classifications. The top row here is the small cell carcinoma. All the other three are the non-small cell carcinoma. You should also know that the small cell carcinoma and squamous cell carcinoma are both centrally located. So they are found in the hilar areas and in epithelial because they originate from the epithelium. On the other hand, adenocarcinoma and large cell carcinoma can be found peripherally. So that is important. We'll look at their histopathology in a second. Important thing to note is that some of these can cause paraneoplastic syndrome by releasing hormones. So in those, look at this small cell carcinoma, very important from the test point of view as well. Very important because it is associated with smoking. Very aggressive. That is why we do chemotherapy. By the time you diagnose it has metastasized. Treat with chemo. Paraneoplastic syndrome associated with small cell carcinoma, C for small cell, and it is ACTH, ADH, and antibodies against calcium channels. So how does that causes Lambert-Eaton syndrome or muscle weakness. So let me show you quickly how does that work. So look at this. Let's say this is a neuromuscular junction. This is the nerve. And here is the muscle end plate. Now we know that there are vesicles, acetylcholine or acetylcholine vesicles that are present in the presynaptic junction, and there are calcium channels that are present, and when calcium comes in through those channels, that calcium facilitates the vesicles to go and bind at the membrane and release their content out in the neuromuscular junction. So once the acetylcholine is released, it will go and act on the receptors on the postsynaptic membrane or the membrane on the muscle. So this is the muscle. Now imagine if you block this calcium channel. If this calcium channel is blocked, do you think that the acetylcholine release will be normal? No. And this is exactly what happens. There are antibodies that are produced when the patient is suffering from small cell carcinoma, and these antibodies come and they attach with the calcium channels, and an autoimmune reaction occurs and the calcium channels are destroyed. So once the calcium channels are destroyed, the calcium does not come into the neuromuscular, into the presynaptic nerve endings. That causes reduction in acetylcholine release, that causes weakness. This also is a reason for the warm-up process. And what is that? Warm-up process is that the patient, when he wakes up, the neuromuscular junction doesn't have enough acetylcholine, and as the patient starts using a particular muscle set, the acetylcholine slowly starts getting released. So in the beginning the patient feels weak, and as he keeps using those muscles, slowly the strength builds up because acetylcholine starts accumulating in the neuromuscular junction. So that is called the warm-up. So this is the Lambert-Eaton syndrome. Remember, myasthenia gravis works on the postsynaptic membrane. So myasthenia gravis affects the postsynaptic receptors, while Lambert-Eaton syndrome antibodies affect the presynaptic calcium channels. Alright, so that is one important one in the small cell carcinoma. The important thing is, the second important thing for the small cell carcinoma, these arise from the Kulczycki cell, which are neuroendocrine cells present in the GIT and the respiratory epithelial lining. These cells normally produce serotonin. When they become carcinogenic, I'll show you a slide, they become deeply blue in color, and you can very easily identify them. They're just lots of blue colored cells. Then squamous cell carcinoma is also central. Normally makes a hilar mass, normally originates from the epithelial area. This tumor can release parathyroid hormone releasing peptide. It's a protein that it releases that stimulates the parathyroid hormone. What is the function of the parathyroid hormone? Take care of the calcium and phosphate balance. The result is hypercalcemia, and so that is the paraneoplastic syndrome associated with the small cell carcinoma. The histopathological feature is the keratin pearls that you can see. So these will be the pink rounded pearl-like structures in the tissue. Adenocarcinoma, most common in non-smokers and associated with the clubbing of the fingers, which is the hypertrophic osteoarthropathies. KRAS, EGFR, ALK mutations occur. Subtypes are three that you should be aware of: bronchioalveolar, papillary, and mucinous. Out of those, the bronchioalveolar, I'll show you a slide for that, are interesting because it appears in the septas. So the alveolar septa look thick under the slide, and that can cause dyspnea as well. And finally is the large cell carcinoma, very aggressive as well, anaplastic, undifferentiated, and usually removed by surgical procedures because it doesn't grow fast, normally present peripherally, but poor prognosis. And that has big joint cells, and they are pale in color, and they have, I'll show you the slides. Cool. So this is a table. So now let's look at the slides. Look at this: small and squamous cell carcinomas. They both are centrally located. Smoking association for the small cell carcinoma, very common. This is more common in men, although it is increasing in women as well. So look at this. These orange cells here, these cells are the This is a pap stain, and these orange cells are the cancer cells. If you see, they have hyperchromatic, irregular shaped nuclei, and that is the important thing to note about them. So this is the small cell carcinoma. Let's look at the, that was a squamous cell carcinoma. Let's look at the small cell carcinoma. Look at this, all those blue cells. What is up with these blue cells? These are actually the cells that are dying. So their nuclei are hyperchromatic, they are deep blue, they are getting necrosed. In here, you would also see some cells, so let me see. You'll see some cells here, possibly this one. Here is another cell. Here is one more cell. So you'll see some cells here that are lighter in color and have a rather open nucleus. These may be viable cells. So you can see both kind of cells present. Again, as I said before, Kulczewski cells are the one that give rise to it. These are neuroendocrine cells that produce the serotonin normally, and then they can become cancerous. This small cell carcinoma, it can produce ACTH and ADH, and as I said, Lambert-Eaton syndrome, when it produces the antibodies, or it helps produce the antibodies against the presynaptic calcium channels. Okay, so this is a combination. This poor patient has small and squamous cell carcinomas both. So if you can see the red cells and blue cells both present. This is the adenocarcinoma, of course, as you can see. This one, guess what is being shown? The septa, alveolar septa are thick, right? So this should tell you that this is an example of bronchioalveolar subtype. Bronchioalveolar subtype usually creates the hypercellularity and tumor in the septa. It grows along the alveolar septa. So of course it is peripherally located because alveoli are peripherally located. And this is the important thing here is the most common cancer in the non-smokers. And it is also associated with clubbing. Prognosis is good, which is a good thing. And look at this. Look at these big cells. So this is the large cell carcinoma, non-small cell carcinoma, large cell carcinoma. This is peripherally placed and poor prognosis, undifferentiated cells. So look at these big pale cells. These are the large cells. Usually in the histopathological slides, you would see these cells, large pale cells with undifferentiated structures, and then peripherally to them you would see the inflammatory cells trying to take care of them. Okay, so this is the large cell carcinoma. Now, complications. So as we talked about Lambert-Eaton syndrome before, some more complications here. So this is a chest x-ray of a 47 years old female who has the Pancoast tumor. So look at this here. It is labeled with P. So she has a tumor that is at the apex of the lung. And of course, over here, it can impinge upon the veins, brachiocephalic vein. It can cause compression and damage to the brachial plexus. It can involve other structures over here as well. So this is the Pancoast tumor. Here is a picture of a Pancoast tumor. So if you see here, this is the squamous cell that is formed a Pancoast tumor. Superior vena cava syndrome. So if central squamous or small cell carcinoma, if they are centrally located, they can then impinge upon the superior vena cava. That would cause the blood returning back to the heart to have difficulty, and that would then cause swelling of the areas which are being drained by the superior vena cava, plus superficial veins will become engorged and bigger and visible on the skin. Why? Because the blood is now being redirected from that to the lower areas, and then it will then come back through the inferior vena cava. So look at this. This is the superior vena cava syndrome. Here on this patient, you can see those engorged and very apparent blue veins. So that is transporting the blood from the upper body to the lower body and then back to the heart. This is another picture of the superior vena cava syndrome. Here, if you see the patient on the left, look at it, 7 a.m. The patient's face is swollen. And then as the patient stands up and the blood starts gravitating from the upper body towards the lower body and then back into the heart, the swelling has gone away. So thank you very much. This was a quick review of the lung tumors. Hopefully you learned something. Please send us a note, go to drbeen.com, register, and there are lots of free lectures there as well. Thank you.